Assistant Director, Provider Education for the Association of Community Cancer Centers, and I'm eager to introduce Dr. Bryan Loy, our expert presenter for the 10th eCourse of the series hosted by the Institute for Clinical Immuno-Oncology, or ICLIO. And he will discuss immuno-oncology, biologics, processes, and issues in setting coverage policy. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by immunotherapy. It includes other vital resources such as newsletters, papers, a scholars program, and a national conference, which will be held this year, September 30th in Philadelphia. Please visit our website, www.accc-iclio.org, to browse all of the offerings. Now for today's eCourse, I'd like to introduce Dr. Bryan Loy, who's Vice President of Oncology, Laboratory, and Personalized Medicine Health Guidance Organization at Humana. Dr. Loy has served in clinical practice and has extensive experience in administrative roles, including medical directorship for a third-party administrator, medical director for a Medicare Part A and B contractor, and his current roles for Humana, a commercial Medicare health plan. In his many roles, his objectives remain to provide members with support across the wellness and healthcare delivery continuum and to provide clinical consultation for commercial clients and other stakeholders, design long-term solutions. And we'd also like to we'll be joined by Dr. Bill McGivney, who's a principal at the McGivney Global Advisors, who will pose questions to Dr. Loy at the end of the presentation. So just for a few housekeeping notes, feel free to submit questions anytime during the presentation by typing your question in the box on your dashboard. All questions will then be posed at the end of the presentation. And the presentation will be archived and available on the ICLIO website within a day. Now I'll send it over to Dr. Loy to kick off the webinar.
Well, welcome everyone and good afternoon. I'm Bryan Loy, and it's an exciting time. It's exciting to be talking with you today about immuno-oncology agents because they really do represent a significant clinical breakthrough and provide some options for folks that are living with previously incurable cancers like lung cancer and melanoma. And I'll be giving you a health plan's perspective on setting coverage policy for immuno-oncology agents like the PD-1 and PD-L1 agents. I'm first going to spend some time with you providing some perspective on our business and then talk a bit about coverage processes and why we need them and how it works with our health plan. And then I'll get to some specifics about immuno-oncology agents and how they've impacted the way that we think and how we're reacting. So every day my company looks to me to make sure we're putting in the necessary measures and processes in place to see that our members are getting the best experience based on the most current science while they're fighting cancer. We're looking for the best value for the dollars that we know we're going to have to spend, both in the delivery of acute care as well as making sure that they have the best survivorship experience. And to that end, we collectively think about the member clinically. We think about how do we get, in a world of vast choices, how do we get the most effective and least toxic, if we're talking about drugs, and then if there are multiple options, how do we get to the least costly alternative? And we don't stop there. We also think about logistics. We don't try to save nickels at the inconvenience of getting an injection that could have been given daily when there's an option for 7 days. And that becomes extremely important when you start to think about travel and the experience of the member. And financially, we really begun to think more deeply about the member experience and whether or not they're able to afford the cost share, because ultimately if the prescription's written and there's lots to follow up, or the prescription is not filled, or the member's not compliant, no one benefits from the treatment plan. So we think about all of these things in concert across our organization. And let me tell you a little more about those nuances because I think it will help you understand and appreciate perhaps the way we're structured as a business. Humana serves government business, employer groups, and individuals. Most of our revenue comes from Medicare Advantage. And that's important for you to understand because when you retention, typically seniors stay with our Medicare plans for quite a long time and they don't change plans year over year. So from many perspectives, we have the luxury and we are interested in the long-term experience of our members. We're not on a year-to-year time frame. And also in aging populations, there's plenty of cancer impact, and we have to think about caregiving, and many of these members are living with multiple chronic conditions. They're not just living with cancer alone. And I would also note that while we do have a significant percentage of Medicare Advantage, we also have a sector, and a very strong sector of employer group and in products. So we'll also talk about the policy development from that perspective as well. I also want to point out that my company not only provides health plan benefits, we own our own pharmacy benefits manager. We also have mail order and other pharmacy capabilities. And that's important. It's an important asset given that it allows us a broader view longitudinally of the member experience in the delivery of care, but also in the out of delivery experience when folks are supposed to be taking their medication. So we can measure metrics like refill compliance, etc., in combination with some of the signals and the data that we get from the health plan side. So policy is core to many of the health operations that we conduct on behalf of our clients and as well as our members, and our biggest client being the federal government. And after we develop policy, like most health plans, we use it to let our doctors and our members know about coverage expectations as we see it. And we acknowledge that policy never covers every possible clinical situation, and we go to great lengths to make sure clinicians are involved in the development as well as the execution of policy. And if you'd like, you can see some examples of our policy on our website. It's www.humana.com. So policy forms the basis of pre-authorization and review, as you know, but there are other purposes. But in short, it provides coverage expectations that allow the providers and the member to know what to expect, and that's important, especially when you're talking about $10,000 a month drugs. You know, we create a lot of frustration if we deny that on the front end, only to overturn it in grievance and appeals processes. So we're very interested in the efficient coverage determinations, both administratively and on behalf of the member. But it also serves some other important purposes that I'll tell you about later on in the discussion. Lorna, if we could, let's go on to the next slide, and I'll dig into some policy development. So like most health plans, we evaluate evidence and society guidelines and all the recognized compendia for infusibles, injectables under the medical benefit side. And similarly, we evaluate the same for orals and self-administered agents administered under the pharmacy benefit. And we rely heavily on medical oncology consultants in the process to consider the comparative effectiveness and the safety of the drug. So once we complete our assessment, we can apply our policy to commercial fully insured business, and generally our self-funded customers apply these same policies. So in the commercial fully insured world, these are subject to state mandates. So you might see a bit of variation in terms of how we're able to apply and or execute those policies. Now when it comes to Medicare, we have to respect national coverage determinations, but I think relevant to this conversation on drugs, we have to respect the local contractor for any local coverage determinations developed by the Medicare contractor, where they have jurisdiction where we do business. So we're allowed to apply our policies when they are similar or less restrictive, but whichever policy is less restrictive for coverage, that's the one we use. So not surprisingly, we're more alike than different, given that we use peer-reviewed literature and we use the same compendia and the evidence levels when we develop policy. We invest a lot of time in Humana communicating between our pharmacy and medical benefits sides of the house, and this is really pretty easy given that it's routine now that we have this era of companion diagnostics, and those end up getting evaluated under the medical benefits side, but they inform coverage determinations on the pharmacy side for oral agents and also on the medical side for the infusible agents. So it's become a natural progression. We've learned a lot as a part of that integration. So when it comes to executing on our policies, we're a bit unique in that we look at the entire treatment plan rather than drug by drugs and insisting on pre-auth around single policies. So we're looking at the chemotherapy, any biologics, and the support agents. So we're reviewing the colony-stimulating factors, the red and white cell growth agents, as well as the anti-nausea and vomiting drugs, and any bone-modifying agents, along with any of the companion diagnostics which are now being incorporated into the FDA approval process. when those test results can help us to clearly identify who will and who will not benefit from therapy. So after our policy has gone through a broader review process, like P&T committee or pharmacy and therapeutics, we then post our policies on our website and communicate that with our vendor partners. Lauren, can we go to slide 3? So we consider the FDA-approved labeled indications, as well as evidence in peer-reviewed English spoken literature and the recognized compendia, and there's usually no argument around level 1 and level 2 assessments. When we develop policy, we also discuss with our medical oncology consultants, as I said earlier, and given that we don't live in a perfect world, they provide us with valuable feedback that help us to better understand off-label requests. So one thing that our vendors have provided us is the capability to give us signals from the provider world, given that they're in the assessment of the chemotherapy plan, and they can help us to understand ordering patterns from the provider. I'll give you a few insights on a bit later. Well, most health plans have periodic review processes of their policies, and they evaluate literature as it's presented. When there are breakthroughs, there's typically an approval followed by a period of rapidly evolving evidence, and it requires us, the health plan, to stay on top of any of the consensus statements that come from the recognized compendia. Well, this rate of change is such that we are finding ourselves more frequently evaluating our policies and our processes and seeking information from the field. And we have to evaluate as frequently as the change dictates, and coverage has to stay in lockstep with the credible science. Otherwise, we lose credibility with our providers, and we get a lot of resistance from our members that are patients and also our employer groups. So it's really essential that we stay on top of the evolving literature. And again, our front-end processes and our feedback loops that we've established allow us to keep our finger on the pulse of the off-label demand as well as the evolving literature. So what makes policy and the associated operations different now that these immuno-oncology agents are on the scene? And I think probably the biggest piece, and none of these are new, but we're dealing with accelerated approvals from the FDA. And then number 2, I'd say the indications are evolving rapidly, and maintaining accuracy of our policies requires more frequent update and publication. And number 3, these agents are now being given in combination with other agents, and they have significant side effect profiles that we're still learning about. Lorna, let's go to my final slide here. I'd like to talk a bit about challenges and some of the roles that our vendors play. So let me elaborate a bit. Some of the indications for these agents, namely the PD-1s and PD-L1s, came to market with overall response rates as their clinical endpoint. So we're living with a bit of ambiguity. So for example, knowing that perhaps only a third of those eligible would be expected to respond, we would want to know whether patients are responding or not. But to say in policy you're covering for those who are responding presents a bit of a problem. How do you assess tumor response and when? The clinical trials that brought these agents to market were imaging at 12 weeks and using imaging criteria that is not commonplace in clinical practice. So it becomes difficult to assess response when the right imaging criteria are not used. And furthermore, given that these agents are promoting an immune response, there may be some confusion with increased immune responses on the image being interpreted as new or changing tumor sites. We're also learning that the nature of these agents may produce a delayed response. So setting criteria is a work in progress. We're starting to see literature that supports the use of these agents in different tumor types. We started out with lung and melanoma, and now we're starting to see renal cell, head and neck, some of the lymphomas, Hodgkin's disease. We're starting to see different dosages. Some of the clinical trials, we saw dosages, but really we didn't see much clinical benefit. And we're seeing these different combinations coming to us. We look for this to expand over time, not diminish. So looking at these agents and the combinations in an efficient manner becomes especially important. And with the recent mention of the Moonshot Initiative, I think we can expect an even greater acceleration of the evolving evidence. Another interesting issue is establishing eligibility of these agents based on companion diagnostic testing. It appears that the test allows us to determine who might best respond, but we're still not completely clear on whether or not the test would tell us whether or not we would do more harm than good to treat a patient with a suboptimal test result. And we're a bit early on to demonstrate that the test result would be sufficient to tell us not to treat in instances where we've run the test. Said differently, we can't use the test result to demonstrate that someone won't benefit for the therapy. Furthermore, these tests haven't been validated for these other evolving indications as well. So in general, we still have a lot of learning to do on eligibility for the drugs and assessing the response of these agents. So as an aside, we're also very interested in seeing whether or not these patients respond in the neighborhood of a third or so, like we saw in the clinical trials that brought these agents to market. And we're going to want to watch these over these populations. So intuitively, you would suspect that the younger populations who don't have comorbidities might be able to tolerate these therapies a bit more so than a frailer and older population. And our preliminary data suggests there may be some important variations in our population, but we think we're still too early on to arrive at conclusions. If we look at these populations and they're only getting one dose, we're going to want to know if there are tolerance issues or folks were later on in their disease progression when they initiated these therapies and other root cause issues. Which really leads me to the side effect point. The adverse event profile of these agents is not trivial. So again, in an elderly population with multiple comorbidities and performance scores of 2 and 3, we're thinking those elements should be considered, and we're watching how members are tolerating these agents and how their immune-mediated side effects are being managed. They have no access to a treating oncologist. They're likely to show up in an emergency department without much history, and the patient is likely to be admitted. And if the emergency department doc does not have the history and doesn't know the side effects are immune-mediated, we run the risk of mistreatment. All very important considerations when we think about the member experience and the perspective. So as a health plan, we are and remain very interested in the member experience and are looking to partner with doctors that are using these agents to increase their education processes and planning with members and caregivers and providing 24/7 access for those medical oncologists and advanced oncology trained professionals to manage those patients. So we've got a window. We're not waiting around on claims payment to get those signals. We're getting those uptake patterns and adoption patterns from the pre-authorization and the chemotherapy request from our front-end vendor processes. Well, let me give you a few miscellaneous points here, and then I'll wrap up. As a payer paying claims, we're heavily reliant on coding accuracy. We noted the use of non-specific HCPCS codes after the creation of the drug-specific HCPCS code. So we watched folks submit claims and when there was a more specific code. And administratively, it slows the payment process, but it also clouds the population view of our data. And we're very interested in creating processes to clean that up, and policy provides us that mechanism to give coding information, and updates will create timeliness, and the coding will become cleaner in our claims payment system, reduce that administrative burden, and provide us clearer and more accurate data to be able to report out on. So if we get claims payment accuracy, we can combine that with the other signals that we get, namely through our front-end processes, and we can obtain a better view on data that's not only worth evaluating, but also worth sharing back with our providers and to researchers and folks who are looking to figure out if there are nuances that we might be studying further. We're also interested in the front-end interactions that take place with our vended partners, the New Century Health and the oncology analytics folks that you see listed on the slide. They help us to understand the off-label request patterns in use, and they also help promote getting to coverage if there's supportive literature or acceptable alternatives. Plans don't typically hire medical oncologists to do cancer-specific review work, and we found this to be an extremely valuable asset. About 4 years ago, we partnered with these companies, and they helped reduce administrative burden, facilitate some discussion, and get to more efficient coverage determination. But equally as important, they help us to understand clinically how new technologies are being adopted in ways that we would never get from our claims data analysis. So as we continue to watch the demographics and looking for stratifications of our member populations and how folks are tolerating and how they're reacting and how folks are treating around these new agents, there will be opportunities for us to learn and share that learning with providers, and when we're exceeding expected response rates, we can ask and learn why. And when we aren't getting those response rates, we can ask the why nots as well and have informed conversations with providers that are prescribing, hospital systems that are interested in, as well as researchers. These insights can be very valuable in sharing and through publications. So let me summarize by saying policy and policy development is a key component, actually a foundational component of our operations to make sure our members and our providers have access to coverage for rapidly evolving technologies and making sure that we can demonstrate to our customers that we're providing coverage for up-to-date therapies that should be available to their membership. And two, that it's foundational to make sure we're aligning our front-end processes to gather clinical insights that we would not be gathering by claims data alone. And that as we learn, we will be able to share in a credible way information that will help promote the effective use of these agents to hopefully affect some positive change. So I'm going to stop there, and Bill McGivney, if I could turn it over to you, I'd like to.
Yeah, sure. Great presentation and really important points you made. I would actually, since I would just kind of tag on to the end there and just ask maybe you to elaborate a little bit more about kind of the technology assessment process under the medical benefit with respect to, again, these immuno-oncologic agents, but also everybody understands, or at least some people do, that as a payer organization, Humana is covering the whole area of medicine, or all the areas of medicine, not just oncology. But if you could elaborate a little bit with respect to the determination of coverage policy based on technology assessment, kind of on maybe 3 fronts. The extent to which, and I believe you have an internal technology assessment organization, but the extent to which they get involved with specific evaluations or assessments of specific agents for specific indications, the extent, you alluded to New Century Health and or oncology analytics, to the extent that they actually do evaluations or tech assessments for maybe brief ones, and do you use any other outside groups as kind of the third component, like the Hayes Group or ECRI, that I know work a lot in the payer and with payers in the payer sphere?
Yeah, I think yeah, it's a great question, and I think the answer is yes to all 3. I would tell you that, like other payers, we have, clinicians internally and that give us guidance in terms of what our boundaries are by plan type. And from the world of pulling in subject matter expertise, we not only have internal, so we've got clinicians, docs, and board-certified oncology pharmacists that are part of our P&T process. We also invite folks externally into those discussions as well. And we do have exchanges with the folks who are on the front line doing the review work for us, again, our vendor partners, and I'll call it the licensed review agencies that you described. We do use those, but we typically find ourselves looking to those organizations for technologies, etc., and probably a little more reliant on our internal clinicians and medical oncologists for those sorts of issues in the pharmacy world.
just to follow on a little bit, so when we move from internal assessments, internal expertise to the outside, when you look at the 5 recognized CMS or recognized by CMS drug compendia, is there any kind of preferred ordering, if you will? For example, is NCCN kind of a higher priority or higher value or higher weighted compendia than any of the others, or is DrugDex, or they all kind of, you look at them the same in terms of their pronouncements?
We find ourselves looking at all of that information, gathering that information, but I would just tell you this is probably more observational. When folks provide input to us, it seems that NCCN becomes the one area that gets referenced the most. It's given a visibility. They seem to update quite a bit, and we find ourselves responding to more questions from that compendia versus some of the others.
Okay, great. A more specific question here, and that relates to, again, kind of a fast pace of advancement, whether it's new agents, new indications, and new combinations. And this gets a little specific, but it's an important issue because I think it's occurring more frequently out there in the practice world across practices, groups, and centers. And that relates to the fact that, if you've got 2 drugs that are approved by the FDA and say NCCN recommended for non-small cell lung cancer individually, and say we have drug A and drug B, but no organization has looked at, including NCCN, drug A and drug B in combination. So they're approved as monotherapies, say, for non-small cell lung cancer, but if you got a request to certify coverage for drug A and drug B in combination to treat, whether it's first line, but basically the same line as FDA approved or NCCN recommended for the individual drugs, would you cover that combination since those 2 drugs are already approved for that tumor type?
Yeah, I would think, if I'm hearing you correctly, if you're saying, do we see evidence for monotherapy, but the request comes in as a doublet, would we want to provide coverage for the doublet when it hadn't been studied? Is that what you're saying?
Yeah, that's, well, yeah, I didn't add that hasn't been studied, but I mean, there might even be, let's put it out there, maybe there's a phase 2 study out there for the combination. But yeah, again, nobody has evaluated it like NCCN or FDA or even others as a doublet.
Got it. I would say the short answer to that is we would have to take a long, hard look at the phase 2 study and see that it was applicable to that patient. But if you're asking for a general coverage, we would probably not see that in policy form. But as I said early on, we don't ever expect the policy covers every single clinical situation, but those phase 2 studies, and we generally don't pay attention too much to abstracts. We'll look at them, but in terms of making coverage determinations, we've got some pretty prescriptive rules that we're asked to abide by from the government, and then we also, I would say, just from a commercial perspective, we're very interested in making sure that those types of requests would be evaluated on a case-by-case basis, and if there wasn't good literature or it didn't feel like it applied to that particular clinical situation, we would probably not provide that coverage.
Okay, thank you.
We would be looking for alternatives, and clearly if there were no alternatives, that would be considered as well.
Okay. Going back more generally, so it seems like everybody wants to get into the, have some type of value product out there. So yes. As you well know, we have the NCCN evidence blocks, and with the ASCO value scores, and ICER up there in Boston trying to bring the United Kingdom process to the United States, and up at Memorial we've got the Abacus. And I'm just going to focus on 2 of them, NCCN and ICER, because actually I think they're going to end up to be the most impactful. So you have the NCCN evidence blocks. I mean, are you looking at those as a way to kind of further, or to use in a further, more extensive evaluation of drugs and biologics for coverage, or even for some type of step therapy?
You know, I won't tell you that we've incorporated that into our policy development process. We're certainly taking a look at that type of information, and we're beginning to ask the questions of, where do lines get set? But, to that end, we have policy and coverage that we're positioned to make sure that we get efficient coverage determinations. But we also have, we haven't really talked about this so much, but a pathways type program that puts comparative effectiveness out for folks to say, rank order, these look like equal agents, here's the least costly alternative. And we're beginning to think about how do we interpret the most credible information from some of the groups like you're talking about and others into those sorts of strategies to say, are there ways for us to identify, and are there ways for us to incent what's right, incorporating, and by the way, in this order, effective, safe, logistically practical care, and then begin to incorporate some of those economic analyses that you're talking about and reward in that way. So, that can come through non-policy type means, like pathways might be one, through contracting initiatives might be another, but it all is very contingent on being able to get credible information in a timely fashion, because we're working in this world of rapid change, and you not only have to keep up with the science, but keeping up with the, I'll call it the parallel economic analysis, is no easy task. So I don't think we've mastered how we might be able to incorporate that in a high change environment. Much easier to think about in a more stable environment. Does that make sense?
It makes a lot of sense, and my follow-on would be, and not just for Humana, but do you see this ICER organization, being impactful or influential as it grows over the next year or two?
I think the short answer is that a lot of folks are paying attention. I can't speak for my competitors, but I would say, they're asking the questions and at least attempting to answer the similar questions that we are. So, we're paying attention.
Okay, I just have this is kind of an interesting question that has come up over and over. I don't know if you're old enough to remember the NIH consensus conferences, but they were held in the open, and there were important clinical issues raised. I mean, do you think that organizations that develop guidelines and pathways and compendia with their committees and groups should hold their meetings in public? We talk a lot about transparency, but there seems to be a substantial need really to hear some of the discussions that go on, which actually could be incredibly educational, I think, for a variety of different stakeholders.
Yeah, and I will tell you that, the NIH Consensus Conference forum that you're describing is, and I think even Medicare to a certain extent has open forum to be able to let folks know what they're thinking, receive notice and comment. I think those are very healthy environments. And to the transparency piece, I would say, when you have commercial folks involved in it, there's competition, and for some folks there's proprietary issues dealing with pathways. But I will tell you, at least in my company, we've tried very hard to be transparent with our participating providers, and not only show them what the pathways are, but also encourage them to weigh in on the pathway development process. We find that we don't have to go seeking that information from providers where we have a large market share. Said differently, they have a lot of Humana members, because my sense is, and it's played out over and over, providers want to do the right thing for their members. And if there's an option and our pathways aren't up to date, they're not bashful about bringing that to us. So there is a sense of transparency and collaboration that's baked into the relationship. I think what you're speaking of is there a way to standardize that in such a way to get all of the pathway partnerships out in an open forum to be able to have that discussion to more standardize that, if I get the intent of your question.
Actually, I'm less interested in the standardization, and I won't get into it deeply. In terms of just openness, we all talk about transparency, and I think the issue becomes, well, the ultimate transparency is to, you could have an executive session in part like the NIH consensus conferences used to, but to really talk about the data in public and, what the experts' views are, which I think would be incredibly educational for, certainly for providers, for patients, for anybody making a decision, whether you're a payer or whether you're a biopharma company. But we can discuss that at length later. I just have 2 or 3 more questions. One is, so I think you alluded to it, and I know it's probably something you're tracking, but the whole issue of overexpression of PD-L1 and, I mean, do you have any current view in terms of biomarker requirements in your policies regarding checkpoint inhibitors?
Yeah, that's a great question. Yeah, and just to be transparent with you, we struggle with the biomarkers issues on a number of different fronts, and we could probably do an entire session on what are the issues associated with those markers. But just in short, there's a lot of variation that still exists out with the test, and some of that standardization has been looked at by the pathologist, and I think we're still in a learning phase about how good of a predictor that is and what are the issues and the variables that will impact that result. But let's pretend that that's all accurate and valid, and that the same test used in the clinical trial on that population that brought the drug to market produces the exact same results. I think the tool that you have today would help you stratify who's going to do better versus who's not going to do better, but I don't really think the question's been answered of who's going to get harm based on the test result or that won't benefit from the treatment. So you begin asking the question of, if you use that tool to understand whether or not they'll respond to therapy or not, and you're going to do something with that information, well, we'd be all for seeing that tool used. But if you're using that tool, the PD-L1, and you're not going to respect the answer, or you're not going to do anything with that answer, then we begin to ask the question of, so why did you order the test to begin with if you're going to treat anyway? So I think that there's a nuance there that we and other payers are going to have to struggle with, to say, why do you want to use that? Why do you want to create policy for that particular biomarker if ultimately it may not impact the decision to treat or not? And there may be some good reasons. We might want to get that information to say, well, let's track those folks over time to see how the 1 to 49% positivity and the less than 1% positivities do respond over time, and is it playing out like we saw in the clinical trials and the evolving evidence, or is it not? Because we've got a front row seat to be able to watch those members over time if we're able to catalog that pathology information. That doesn't come in on a claim, so we've got to go after that in some way and work with providers to get that information if we're going to be about tracking the outcomes associated with those test results.
Yep, interesting area. Final question. So final question is, so we've got all these, and this is a more general one, payment methods that we've been talking about, seems for years, trying to move away from strict fee-for-service. So you have fee-for-service plus incentives, or I'm cutting it down here, or more episodic or bundled payments. So obviously we're going to see, we're going to see the anti-PD-L1 soon. We're going to see all sorts of combinations coming. We'll probably have indications across many more solid tumors and moving into the hematologic malignancies. Is Humana looking at all to implement in a fairly broad way and any of these, say, fee-for-service plus incentives, third-party plus incentives, or more episodic bundle-based payments in oncology? Let's focus on oncology.
Yeah, we've had some deep conversations with folks, and in general, you start to get into the, okay, so if we're going to move away from fee-for-service and start thinking about new payment models, folks are pretty open to the idea of improving the total cost of care. But in the world of changing and evolving agents, it gets a little trickier because folks then turn back to providers ordering medical oncologists, or then coming back to us and saying, so can we carve that out, or can we deal with that separately, or are there ways for us to mitigate that risk of new agents coming to market, because we don't know what will be here this time next year. We've got a pretty good idea, and we know the pipeline is replete with possible options, and not knowing what the prices are, but the prices thus far, if past performance is any indicator of future, the stakes are fairly high. So some systems aren't large enough to absorb or take on that risk, and some of the smaller practices definitely aren't able to take on that sort of a risk of those new agents coming in under a fixed payment sort of a model. Now, having said all of that, we do believe that there are a number of opportunities. So as we've said, as we learn, we share, and we begin to find out, adverse event profiles provide opportunities, and some of these combinations begin to inform opportunities about what can we do to have deeper informed consent discussions with patients, our members. What can we do to plan around what to expect out of the agent and for how long, and what are the financial implications, what are the risks and benefits clinically, and what is your willingness to withstand these. So we are now starting to get into the importance of patient value discussions. And we then, and this is starting to move towards a medical home type discussion, but we start to talk about, who are those practices that are going to put in the necessary infrastructure, if you will, to educate their patient, do a deeper, I'll call it, exploration of patient values, and those folks who are going to put in the accessibility and the accountability to manage side effects and understand patient values and begin building that out. Well, then we as the payer play a role in, so how do we begin to fund that and measure the success of that? So those are many of the things that we're beginning to think about in choosing our partnerships with folks who are moving down that parallel path.
All right, terrific. I'd just like to thank you personally, Dr. Loy, for your always thoughtful and complete, but most importantly, direct answers to the questions, providing guidance to all those that are listening in. So with that, I will turn it back to Lorna Lucas.
All right, thank you.
Thank you.
So thank you both to Dr. Loy and Dr. McGivney for joining us and for the really insightful presentation. And thank you to our audience also for participating. Again, the webinar and slides will be available on our website, which again is accc-iclio.org. And all registrants will also receive an email. So if you have a colleague or someone missed it, we'll also be emailing them as well. And we also hope you'll register for our upcoming webinar on February 23rd at noon. The topic will be on immuno-oncology combination therapies, and that will be with Dr. Igor Kuzanov. So thank you so much, and have a great rest of your day.